Welcome to the Cardiovascular System and Engineering Perspective. In this video, we will perform a systematic deconstruction of the body's most critical life support network.
First, we must define the engineering problem, servicing 37 trillion cellular clients. The human body is a complex metropolis of trillions of individual cells. As shown here, each cell requires a constant, reliable supply of oxygen and nutrients alongside an efficient system for waste removal. This poses a critical design challenge. How do you construct a logistics network capable of servicing every single cell 24/7 without fail? The solution to this problem is the master blueprint, two circuits working as one integrated system. First, we have the pulmonary circuit, which serves as the refueling loop. Its path runs from the heart to the lungs and back. Its primary function is oxygenation, sending deoxygenated blood to pick up oxygen and release carbon dioxide. Second, we have the systemic circuit, acting as the delivery loop. This path extends from the heart to the entire body and back, distributing oxygenated blood to every organ and tissue while collecting waste for return. At the center lies the powerhouse, a precision dual-action pump. Crucially, the heart isn't a single pump. It consists of two pumps synchronized to work in perfect concert. The right side powers the pulmonary circuit, while the left side powers the systemic circuit. Together, they form a continuous closed-loop system. Now let's trace the flow of blood through a complete journey. First is the systemic return. Deoxygenated blood from the body enters the right atrium via the vena cava. Second, it heads to the lungs. The blood is pumped into the right ventricle, then out through the pulmonary artery. Third, we have oxygen reload. In the lungs, the blood releases carbon dioxide and picks up fresh oxygen. Fourth is the pulmonary return. Oxygenated blood flows back to the left atrium via the pulmonary veins. And finally, it travels to the body. It is pumped into the powerful left ventricle, then ejected out through the aorta to the rest of the body. So, what is in a name? In anatomy, it is about direction, not content. The most important distinction between arteries and veins is the direction of blood flow, not the oxygen level of the blood they carry. The rule is simple. Arteries carry blood away from the heart, while veins carry blood toward the heart. This creates what we call the pulmonary paradox. Unlike systemic vessels, the pulmonary artery carries deoxygenated blood away from the heart to the lungs, while the pulmonary vein carries oxygenated blood toward the heart from the lungs. In the vascular network, form truly follows function. Arteries serve as high-pressure conduits. They possess thick, elastic, muscular walls, specifically the tunica media, which allow them to withstand the pressure generated by the heart's contraction and smooth out pulsatile flow. Veins, conversely, are low-pressure return channels. They feature thinner walls and a larger lumen designed to return a large volume of blood to the heart. Unlike arteries, their structure is not designed for high pressure. The question arises, why is pressure high in arteries but low in veins? As the graph illustrates, pressure is highest in the arteries because they receive the full, powerful force of blood ejected directly from the heart. By the time blood reaches the capillaries, pressure drops to a medium-low level, which is necessary to allow for efficient substance exchange with tissues. Finally, in the veins, the pressure is very low because that initial force has dissipated. Here, flow relies on muscle contraction and one-way valves to return blood to the heart. Next, we examine how the body engineers a one-way flow using the venous valve. The challenge here is gravity. In a low-pressure system, we must ensure blood in the lower body returns to the heart without flowing backward. The solution involves equipping veins, particularly in the legs, with a series of one-way valves. As you can see, when surrounding muscles contract, they squeeze the veins, pushing blood past a valve. The valve then snaps shut, effectively preventing any backflow. Now we look at reading the system dashboard, blood pressure and pulse. Blood pressure measures the force wave generated by the heart within an artery. It is recorded as systolic pressure, the peak during contraction, over diastolic pressure, the minimum when the heart is relaxed. A standard reading is approximately 120/80 millimeters of mercury. The pulse is the tangible pressure wave itself. When you feel a pulse, you are actually feeling the expansion and recoil of the arterial wall, not the physical flow of the blood.
Finally, we identify the diagnostic access points for locating the pulse. There are 4 standard arteries used for this assessment: the carotid pulse in the neck, the radial pulse at the wrist, the femoral pulse in the groin, and the dorsalis pedis pulse on the foot. Clinically, physicians use these locations not just to count heart rate, but to assess the rhythm, strength, and equality of blood flow to different parts of the body. Let's take a deeper look at the diagnostic applications of these 4 specific pulse points. The radial pulse, located at the outer wrist, is the most common site for routine checks due to its easy accessibility. The carotid pulse, found alongside the larynx, provides the strongest peripheral pulse. It is crucial in emergencies, such as cardiac arrest, when other pulses may be too weak to detect. The femoral pulse in the groin is used to assess circulation to the lower limbs, often during emergencies or surgical procedures. Finally, the dorsalis pedis pulse on the top of the foot is critical for assessing blood flow to the furthest extremities, particularly in patients with diabetes or peripheral vascular disease. To evaluate system performance, we calibrate heart rate into 3 distinct categories. First is bradycardia, defined as a heart rate of fewer than 60 beats per minute, which is considered slower than normal. Second is the normal resting rate, falling between 60 and 100 beats per minute, the typical range for a healthy adult at rest. Third is tachycardia, referring to a rate exceeding 100 beats per minute, indicating a rhythm that is faster than normal. However, a clinical insight is required here. Elite athletes often have a resting rate between 45 and 55 beats per minute. This is not a sign of a problem, but of high efficiency. Their stronger heart muscle pumps more blood with each beat, resulting in a higher stroke volume, so the heart needs to beat less often to meet the body's needs. Now we measure the system's throughput, known as cardiac output. The formula is simple. Cardiac output equals stroke volume multiplied by heart rate. Stroke volume is the amount of blood pumped from the left ventricle per beat, while heart rate is simply the number of beats per minute. Let's look at a practical example. If a heart beats 70 times per minute and pumps 70 milliliters of blood with each beat, the result is approximately 4,900 milliliters or 5 liters per minute. Remarkably, this means the heart circulates the body's entire blood volume, about 5 liters, roughly once every single minute. We conclude with the control system, an intelligent hydraulic network. The cardiovascular system is not static. It is a dynamic network that intelligently adjusts to meet the body's changing demands via a central control unit. This unit regulates 3 specific parameters. First is vessel diameter. Through vasodilation and vasoconstriction, blood flow is redirected. For instance, during exercise, vessels in the muscles dilate to increase blood supply, while those in the digestive system constrict. Second is heart rate, which modulates the frequency of beats per minute. And third is stroke volume, allowing the heart to adjust the force of its contractions to pump more or less blood per beat.